All right, so this lecture will discuss the medical nutrition therapy for intellectual and developmental disabilities. All right, so to review a little bit of background, we have the Developmental Disabilities Assistance and Bill of Rights Act. So kind of looking at how these are defined. So a severe chronic disability of a person attributable to a mental or physical impairment or combination of mental and physical impairments. So manifested before age 22, likely to continue indefinitely, and there are substantial functional limitations and not a disease process. So there's disabilities for that as well, but again, we're looking at a developmental disabilities assistance. So again, we're looking at like a subcategory. So these are defined as severe chronic disabilities attributable to mental or physical, again, manifested before age 22, and results in substantial functional limitations. So intellectual disability has replaced the term mental retardation. Again, so this is the most common developmental disability. Multiple causes, though, including congenital anomalies, specific syndromes, neuromuscular dysfunction, neurological disorders, prematurity, cerebral palsy, untreated inborn errors of metabolism, toxin exposure, and nutrient deficiencies. So principles of nutrition care, so our focus, so we know that nutrition is an essential component of comprehensive care throughout the life cycle, as again we discussed with the previous lecture, and so a variety of nutrition problems depending on the disability. So things that we want to be looking for in our assessments with these patients is going to be anthropometrics, so again we may need to be using modified methods to obtain accurate data. And biochemical assessment, again being able to interpret it in context, so for example, anticonvulsant medications may decrease blood levels of some nutrients, thyroid status test for patients with Down syndrome, and glucose tolerance test for patients with Prader-Willi syndrome. And so again, we will be monitoring dietary intake, so again, looking at growth and development and dietary intake. So here we can see some modified methods. So depending on the schedule when we're back on campus, again, this was what we were going to be doing during the lab portion, was practicing more with these modified methods. So again, depending on, for example, with cerebral palsy, right, if somebody has contractures or an altered gait, etc., then we may need to use an alternative measurement to estimate height, etc. So feeding issues. So we may encounter feeding issues such as an inability or refusal to eat certain foods because of neuromotor dysfunction, obstructive lesions, and psychosocial factors. There may be oral motor difficulties, positioning difficulties, behavioral issues, self-feeding issues, or sensory and tactile resistance after intubation. So again, depending on prematurity and exposure to being intubated early on, again, the child may be resistant to eating, again, because they don't like the feeling of something in their mouth or their throat. So here we see the proper feeding position for infants. So again, it's that slightly relaxed. I want to say it's like 30 to 45 degrees. And here we can see, so from 6 to 24 months, again, we're sitting more upright. So again, looking at, again, our nutrition diagnosis, which we're familiar with, but our interventions, right? So this is where things get a little bit different from our standard ADIME. So again, we've talked about previously briefly about individualized education plans or individualized family plans. And so again, this is where the dietitian may play a role, which is when you make your interventions of how we're going to fix this issue for the patient to improve their intake, to improve their nutrient sources, right? This is going to also be followed up with that patient's IEP or IFP. Again, so looking at how those are implemented. So we've talked previously a little bit in genomics about Down syndrome. So again, chromosomal aberration of chromosome 21 is the most common form, so trisomy 21. And so what we commonly see is a high BMI with short stature, low muscle tone, and delayed gross motor ability. Patients are often formula fed because of neonatal issues and a delayed progression to solid food, and often have delayed feeding skills. So again, we looked at the previous lectures looking at that change in the pincer grip and the wrist movement with continued development. So intervention strategies for patients with Down syndrome. So again, our concern is these patients are very likely to be overweight. So a calorie-controlled eating plan, assessing feeding development, activity level, and environmental changes, and exercise programs for adolescents. Again, continuing to use common sense. We don't need them to exercise, but join sports teams, participate in recreational activities, etc. So feeding skills, right, we want to promote as close to normal as possible. So again, we said there may be delayed feeding skills, but again, we want to continue to practice them and work on them. Constipation is common, again, so because we have decreased muscle tone, that also affects smooth muscle, such as the bowel. So we want to increase fiber and fluid intake, and again, along with the weight management, right, exercise will also help manage constipation. So here we can see, so estimated caloric needs for special conditions. So here we can see for Down syndrome, so we have a difference in calories. Now, these numbers are going to look a little bit different. So these are calories per centimeter. So again, we're going based off of height, not off of weight. So again, what we knew is, again, going back to the previous slide, is that we expected decreased stature. And so that's what we're actually going to use is, instead of using weight, which is likely to be overweight to predict our needs, we're going to be using height. So again, just realize these numbers are not calories per kilogram. These are calories per centimeter. All right, so we'll talk about Prader-Willi syndrome. So a genetic condition caused by an absence of chromosomal material for chromosome 15. So we're going to see short stature caused by growth hormone deficiency. We're going to see low serum insulin like growth factor 1, low IGF-1, and low IGF binding protein 1, and low insulin. And so we're going to see a deficiency in hypothalamic pituitary gonadal axis. So this causes delayed and incomplete sexual development. And so what that is that's the relationship again between looking at growth hormone and then looking at sex defining hormones like testosterone, estrogen, etc. So again, so that interplay between the brain and the pituitary and the gonads to release hormones is affected. So medical nutrition therapy for Prader-Willi syndrome. So again, we're going to see initial failure to thrive, followed by excessive weight gain between ages 1 and 4 years of age. And the most telltale sign, right, and the most commonly asked sign is going to be is uncontrollable appetite, low basal metabolic rate, and decreased activity leading to obesity. And so again, we're going to monitor for diabetes. Again, we looked at the previous slide. So again, because of changes in insulin and blood glucose regulation, diabetes may be common. Infants are difficult to feed because of hypotonia, poor suckling reflex, and delayed motor skills and GERD, and difficult behaviors associated with insatiable appetite in children. So again, going back to the most famous symptom of this condition is uncontrollable appetite. And so then again, this is what you see. So it's usually dramatized on TV, but the core is there, which is that, again, you're usually having to look at, food has to be locked, refrigerators and freezers have to be locked. Again, so that, and this is not their fault, but this is because of that change in those hormones and in that hormonal balance in the brain. Imagine how when you get hungry, but you feel that way all the time. Even when you eat, you feel that way all the time, and that's what it's like for these patients. So again, other things to help benefit and control this condition. So structured meal times. So again, having a planned anticipation for when meals will occur. Small servings with limited sweets, monitoring height, weight, and nutrient intake, and again, environmental controls, which is the fancy word for saying putting locks on cabinets, freezers, fridges, etc. All right, so next we'll talk about spina bifida. So spinal lesions include meningocele, myelomeningocele, and spina bifida occulta. Again, not a huge difference to us so much as what we're going to be concerned with is those functional differences, which again are going to be on an individual basis. And what I can tell you from personal experiences is to have those conversations with your patients and don't make assumptions. So this may cause weakness in the lower extremities, paralysis, skin breakdown because of a loss of sensation, bladder incontinence, hydrocephalus, UTIs, constipation, or increased rates of obesity. Now, like I said, though, from personal experience, I would recommend that you have conversations with these patients about their individual functional levels. So again, I did have a patient who had spina bifida, and they were in for an acute infection, so they had a kidney infection that had become quite severe. But they actually worked, so she and her husband worked on their farm basically full time. And so I don't know if any of you have ever worked on a farm or how much you know about farm equipment or machinery. But working a tractor does not require you to operate foot pedals. It's all hand operated. And so this woman actually worked full time on her farm with her family because, again, she was able to operate the tractor because it was all hand operated. There was no pedals, etc. So again, have these conversations, right? When you just don't make assumptions about patients. I can just tell you it's a little embarrassing from personal experience. So these patients are usually short, and the children are often picky eaters with decreased energy needs. So we want to encourage fluid intake to prevent UTIs. Some of these patients may have swallowing difficulties. Again, our concern is obesity prevention. So again, this is due to decreased physical activity and excessive caloric intake. So again, we just want to look at dietary intake and encouraging physical activity that is tolerated and appropriate. Fiber and fluids to prevent constipation. And a ketogenic diet may help for as a secondary treatment. So if they have, in addition to the spina bifida, they also have seizures, then the ketogenic diet may help. But the ketogenic diet isn't actually doing anything for the spina bifida. It's just helping the secondary disorder from the seizures. So we'll take a look at cerebral palsy. So this is a disorder of motor control or coordination resulting from brain injury during early development. Patients may have poor nutrition status and growth failure, often related to feeding problems. Constipation may appear, so this is usually due to a lack of fiber, fluids, and inactivity or physical inactivity. Again, because of an altered gait, they may not participate in physical activity, so we need to find alternative sources or appropriate physical activities, and possibly dental problems. Other things to consider, so we want to use modified methods to assess weight and height. So again, especially if there's an altered gait, again, it's not they're not willing to, but right, if they can't actually straighten their leg, then we're going to be able to use knee height calipers, we're going to be able to use arm span, etc. We want to assess bone mineral density, so again, altered gait is going to possibly affect that stress on those bones, so that bone mineral density. Keeping an eye on vitamin D, carnitine, and vitamin K. Medications for seizures, if they are on seizure medication, right, we want to be aware of and monitor, so keeping an eye on micronutrients, any nutrition interactions. Feeding issues, and increased risk for gastroesophageal reflux. So we'll talk about our next disorder, which is autism. So one of 5 disorders known as pervasive developmental disorders. So this is the autism spectrum. So in 2014, so the CDC estimated 1 in 68 children have autism spectrum disorder. And so the 2014 estimate is 30% higher than the previous estimate in 2012. Now again, is this because of increased rates? Or again, we've now looked at, so what is considered the spectrum of normal behavior versus abnormal behavior? So again, some of those numbers, right, realize the way stats work, there's 2 different factors at play when you see that dramatic increase. So things to consider, so the disorder, so qualitatively impaired reciprocal social interaction, impaired communication skills, restricted repetitive stereotypical interests and behaviors, and may also have an intellectual disorder. They may not, they may, but again, those would be concurrent, those would not be, it's not one cause the other, it's just both exist at the same time. So nutrition considerations for autism spectrum disorder. So again, may need additional essential fatty acids, antioxidant nutrients, minerals such as zinc, calcium, and magnesium, careful monitoring to minimize mercury intake. Again, you've seen, so allergy and the focus on gluten, casein, and soy, which has very mixed results. Sulforaphane, which is a phytochemical, may help. We want to assess the patient's intake, feeding skills, and behaviors. Again, they may resist texture progression or variety. Again, individualized therapies to encourage intake, identifying different food sources. Again, for example, if the patient's avoiding specific colors, then we may become deficient in certain micronutrients that would need to be supplemented. Next, we'll take a look at attention deficit hyperactivity disorder. So this is a neurobehavioral problem associated with learning disorders, inappropriate degrees of impulsiveness, hyperactivity, and attention deficit. So the medication class that's most often used to treat these disorders is known for causing anorexia or poor appetite. So we need to monitor the growth carefully in growing children. So it's not much of a concern in adults, but especially in pediatric populations where, again, we're looking at full maturation and height and growth attainment. You're going to see they're going to be closely monitored by their pediatrician. Behavioral therapy in addition to medication. Again, the goal is not to just use the medication forever, but also behavioral therapy. So again, looking at whole foods, so again, a balanced diet. And what we do know from our previous lecture looking at psychiatric conditions, so essential fatty acids, and so specifically omega-3 fatty acids, may help with behaviors. Another dietary component that's being explored in ADHD is looking at the exposure to the amount of dye. So the recommended amount of dye for children is 12 milligrams per day. And studies showed that many in the United States get 100 milligrams per day, right, or which would be a little bit less than 10 times the recommended amount. Next, we'll talk about cleft lip and palate. So it's the most common craniofacial birth defect. So surgical repair of cleft lip usually at 2 to 3 months and cleft palate at 9 months. So breastfeeding is usually difficult as it's difficult for the child to make a seal. So education about positioning for feeding, nipple and bottle selection, and close monitoring of intake. And again, individual assessment and interventions. So here you can see cleft palate. So again, the palate is the roof of your mouth, where again, so you can see there would be an incomplete cleft palate, right? You would then have a lack of tissue at the roof of your mouth. And remember, when breastfeeding, right, you actually, right, the baby compresses the nipple against the palate with their tongue. If there's no palate there, you can see why this would be difficult for the child to then breastfeed. And here you can see cleft lip. So we have unilateral cleft lip versus bilateral. Again, in many countries, this is incredibly dangerous, right? You'll see there's typically donations. So this procedure, in the grand scheme of things in medical procedures, very simple, very easy, not a big deal. But in developing countries with a lack of resources, something like a cleft lip actually can be very deadly, right? So we have failure to thrive, and the child literally just can't get enough food to survive. Here in the United States, right, with early intervention, again, relatively, in the grand scheme of things, right, very minor and a very quick fix, and then very little developmental issues from there on out. So we'll talk a little bit about fetal alcohol syndrome. So this is toxic effects of excessive alcohol consumption by the mother. So this causes intellectual deficits, psychological or behavioral problems, and physical problems. So this is diagnosed by growth retardation, specific facial features, central nervous system damage, and again, with a recorded history of prenatal alcohol exposure. Now again, taking a look at these as a whole, these developmental disabilities, so many parents seek hope from unusual medical or nutritional therapies. Again, we've talked about these previously, taking a look at psychiatric conditions and Axis 1 versus Axis 2. With some of these, right, for example, you just are who you are. You can't really be cured of who you are, right? It's not a disease. So again, there's been very inconsistent results in different types of treatments. Again, there may be things that help with management. So for example, we've consistently seen that omega-3s are beneficial, but we've seen a lot of therapies and diets that aren't beneficial and could sometimes be harmful. So again, being aware of specific alternative therapies for specific disabilities, or if parents are engaging in behaviors. Again, we also have to be champions for science and making sure that parents aren't doing anything that's dangerous or could harm their children. So community resources, so again, especially for patients with these types of developmental disabilities, you're going to see a lot more involvement and almost more of a role of a community dietitian. So you may be seeing them as for outpatient therapy, or they may be in for an acute exacerbation, but then realizing that, right, your role is really going to shift and you're really going to be looking at, well, of course you can treat them in the hospital, but what's going to happen when they go home? And so again, looking at the school system. So again, remember that as part of their IEP, that the school lunch and breakfast programs will provide reasonable accommodations, right? So if they need to change textures, if something needs to be chopped up for a child to make it easier to chew or swallow, right? All of that will be done. Again, it just requires a write-up and signing off by that medical professional, aka you. So again, child and adult care food programs, so Individuals with Disabilities Education Act, and again, referrals for special meals, so if things need to be accommodated, again, in the home setting as well. So again, you're looking almost more of a community role dietitian, even though you may be seeing them at times in an acute care setting. And so here's some focal points to just kind of neatly summarize the chapter. But again, I do look forward to your questions and our discussion on Zoom.